All right. Welcome, everyone. I see a number of audience members are joining online. We're just going to give a few minutes for people to sign on. And I just want to extend an incredibly warm welcome to those that are joining from all over the world for our webinar today. Really excited to have an opportunity to share out some of our current and recent research with our trainees here through the Johns Hopkins Bloomberg School of Public Health Evidence Accelerators Program. Just giving a couple minutes for folks to sign on. Okay. All right, great. Well, welcome everyone. I'm Michelle Decker. I am a professor here at the Johns Hopkins Bloomberg School of Public Health and have the pleasure of leading our Center for Global Women's Health and Gender Equity. And I'm exceptionally pleased today to be able to kick off our webinar, Evidence in Focus, Emerging Research on Gender-Based Violence and Gender Equity with results from Kenya, Nigeria, and Ethiopia. We have been running this program for a number of years now. This is our Gender Equity and Gender-Based Violence Evidence Accelerators Program. This is a one-year virtual training, virtual mentoring, virtual coursework with that mentoring element and a number of in-person convenings. And it's really designed to foster and support new researchers and newer researchers really level up in the work that is being done on gender-based violence and other forms of gender equity in women's health, really around the world. Every year we are inundated with applicants, and we're exceptionally pleased to have an opportunity to hear from our scholars today. Our trainees work all year through the coursework and their mentoring on a specific mini project. And today we're going to have an opportunity to hear those results out. We wanted to have an opportunity as well to hear from some of our earlier cohort members. So I'm actually going to introduce and turn the floor over to two of our earliest scholars within this program. I'm really delighted that we're joined today by Dr. Ayo Ayodeji Adebayo from the University of Ibadan, a professor, as well as Nede Benjama, who's a gender and human rights consultant and a master's candidate in international relations at the University of Cape Town. So we want to offer both of you an opportunity to come on screen and share a little bit about the impact of the program on your training and your professional development. So Dr. Ayo and Nede, over to you.
All right. Thank you for the warm introduction. Good morning, good afternoon. It's a great privilege to be part of the inaugural cohort of the Johns Hopkins Gender Equity Accelerator Fellowship. And I owe a sense of gratitude to the director of the center, my mentor, Professor Michelle Decker, and other articulate team of mentors and facilitators. The fellowship meant a lot to me because it has tremendously boosted my confidence in violence prevention in the following ways. First, in terms of perspective, prior to the fellowship, I hardly realized that I had a myopic view of violence prevention. The program has broadened and reshaped my perspective in this regard. In teaching and research engagement, I feel more confident than ever to engage my postgraduate students in violence prevention, content, and interventions. As a matter of fact, the program has given me more courage in rigorous evidence-based design and analysis. It's still about research and better coordinated and more effective as a partner in the Violence Prevention Research Consortium I belong. That's WW2 against women, the prevention of violence against women and girls. In leadership, the fellowship has enhanced my leadership roles in one of the NGOs in Nigeria where I serve as the chair of the board. We currently could do things in better light. Again, still about leadership. During the fellowship, the simplicity of the mentors in teaching and facilitation has positively impacted my current office as the chair of my department. I took on this role after I completed the program in 2024. Regarding networking, I could boldly say that the fellowship has enabled me build a lasting relationship with my cohort, even our mentors. We communicate constantly on possible collaborations and other opportunities till date. Finally, I must admit I feel extremely honored to be part of this great event, today's webinar, and I can't wait to listen to the great work that you have done. And I sincerely hope you find the path constantly memorable in an outstanding way. Thank you.
Thank you, Ayu. Hi, everyone. It's truly a pleasure to be here with you today, and a real honor to return to this space as an alumna of the Gender Equity Fellowship. When I reflect on how this program shaped my own path, one of its most obvious impacts is that it brought me back to academia. The rigor of the fellowship, the emphasis on grounding our work in evidence and engaging critically with research completely transformed the way I approach my work as a GBV practitioner. It pushed me beyond implementation into deeper analytical thinking, and ultimately it led me back to grad school. The fellowship didn't just influence that decision, it actually gave me the tools and the discipline and actually the confidence to take that step. And that's why I'm especially excited to be here today. I'm really looking forward to discovering the questions explored this year, the insights generated, and the fresh perspective this year's scholars are bringing. Because beyond the outputs, what this fellowship really builds is a way of thinking, a habit of asking deeper questions and connecting research to the real world. And of course, as Ayo said, just as important is the community you build along the way. The relationships we formed here continued beyond this fellowship as mentors, collaborators, thought partners, and sources of opportunities and support. And so I'm truly honored to help introduce this cohort and excited to learn more about their work. Thank you.
Wow, wonderful. Thank you both. It's such a treat to have you back in the space as alums and have an opportunity to really bridge across our cohorts like this. So it's just fantastic to have you at the table for this. Thank you both. And now I'm just really delighted to introduce Dr. Rosemary Morgan, research professor here at the Johns Hopkins Bloomberg School of Public Health, has graciously agreed to be our moderator for today, and walk us through and introduce just an incredible set of trainees for this webinar. Dr. Morgan, over to you. Thanks.
Thank you very much. And I'm delighted to be here today to be able to introduce these really excellent scholars that we have. So it's my pleasure to start us off and introduce Josphine Wanjiru Kagucia, who is the Principal Research Officer at the National Gender and Equity Commission in Kenya. And the title of her presentation today is Exploring Femicide in Kenya, an analysis of correlates of femicide by perpetrator relationship. Thank you.
I'm going to present on exploring femicide in Kenya, which is an analysis of correlates of femicide by perpetrator relationship. My main research question was, what are the correlates of femicide by perpetrator relationship in Kenya? And now why we needed to do this mini project, because first of all, femicide is the intentional killing of women or girls because of their gender. And femicide is a rising public concern in Kenya currently, which has been amplified by the media and the civil society. In 2024 alone, 170 women were reported murdered, with the National Police Service reporting 97 women killed in just 3 months. And this is one of the campaigns that was spearheaded by the civil society organizations on ending femicide in Kenya. So, intimate partner violence is a key risk factor for femicide. And intimate partner violence is widespread in Kenya, affecting about 40% of ever partnered women aged 15 to 49 years. Hence, analyzing perpetrator relationships is essential to identify risks, inform interventions, and address evidence gaps. So, from the conceptual framework, we have 2 main variables. That is the sociodemographic characteristics and the dependent variable. So from the sociodemographic characteristics, which includes age, place of femicide, circumstance leading to femicide, mode of killing, and region of victims of femicide in Kenya. The dependent variable is the type of femicide, either is intimate partner or non-intimate partner femicide. The data used for this mini project was from the Africa Data Hub, which contained 492 case-level database compiled from the media analysis from 2016 to 2023. And this study extracted variables from the dataset. And the study used descriptive analysis and compared the sociodemographic variables of intimate perpetrated femicide versus non-intimate perpetrated femicide. Two cases that had missing values on perpetrator relationship were omitted. So the findings show that most of the femicide victims were by an intimate partner at 74%. And looking at the age groups of victims of femicide in Kenya, most of them fall between 18 to 34 years. When we look at those by intimate partners vis-a-vis those by non-intimate partners, those less than 18 years mostly were killed by non-intimate partners at 84%, while those between 18 to 34 were killed by an intimate partner at 81%, and those 35 years and above by intimate partners at 57%. The victims' place of femicide in Kenya, most of the victims died at home at 66.5%, while looking at those by intimate partners versus those by non-intimate partners, most of the victims of intimate partner were killed at home at 84%, while those by non-intimate partners were killed in a public space, either workplace, school, or any other public space. Circumstances leading to femicide in Kenya were identified mainly as unknown, a big percentage unknown at 41.6%. And this was followed by argument at 36.5%, and jealousy at 10.8%. When you look at those by intimate vis-a-vis those by non-intimate partners, which was very significant, by non-intimate partners, all were crime-related. Argument was highest in those in intimate partners at 95%, followed by jealousy at 83%, and then end of relationship at 81%. So the mode of killing of femicide victims in Kenya was mainly as a result of stabbing at 30%, which was followed by blunt force at 15.3%. Looking at the victims of femicide, either by intimate partners or non-intimate partners, we are seeing 100% of those who died by shooting was by an intimate partner. And by non-intimate partner, most of them were as a result of sexual assault at 88.2%. The place of femicide in Kenya, most femicide deaths were recorded in the Rift Valley region, followed by Nairobi. So Rift Valley at 27.8% and Nairobi at 23.7%. And from the bivariate analysis, region of residence for femicide victims was not significantly associated to the type of death. So the implications of these findings is that intimate partners are the main perpetrators of femicide in Kenya, reflecting deep gender power imbalances and making homes unsafe for women. Femicide risk varies by age. Adult women are mostly killed by intimate partners, which is linked to control and conflict, while girls under 18 are mainly killed by non-intimate partners, which can be linked to abuse and exploitation. So most intimate partner femicides occur at home, which is hidden and harder to detect, while non-intimate partners femicides occur in public, which can point to weak community safety. Gun-related femicides involve intimate partners, suggesting misuse of state-issued firearms and gaps in regulation and accountability within security forces. And data gaps remain significant, highlighting the need for stronger evidence systems to inform prevention and accountability. So some of the action steps are in two broad categories, basically on practice, policy, and programmatic actions, and on data and evidence gaps. So under practice, policy, and programmatic actions, we need to strengthen prevention and protection systems, including early warning mechanisms, lethality assessments, survivor protection infrastructure, and firearm accountability systems. We also need to enhance GBV training and accountability mechanisms within security forces, particularly regarding use of state-issued firearms, and strengthen targeted interventions for IPV and child protection, recognizing age-specific risks. We also need to promote multi-sectoral, gender-sensitive policing approaches to improve prevention, response, and community police trust, and scale public awareness and community engagement initiatives to challenge harmful norms and reinforce that IPV and femicide are preventable. On data and evidence gaps, we need to strengthen femicide data systems to reduce reliance on media reporting and improve accuracy. We also need to improve integration of data across police, health, and justice sectors, establish a centralized national femicide database to capture prevalence patterns and risk factors, and standardize data collection tools, including capturing perpetrator-victim relationships. That is it for my presentation. Thank you so much.
Great, thank you, Josphine, for the presentation. What a really sort of important study, and I can already think of a number of questions. So please do add your questions to the chat or the Q&A function at the bottom of the screen. There will be an opportunity for questions after all three presenters have gone. So next we are going to hear from Balem Demstu, who is an assistant professor of maternal and reproductive health and a PhD student at Mekelle University in Ethiopia. The title of her presentation today is Help-Seeking Behavior for Sexual and Gender-Based Violence Within 72 Hours of Incidents in Tigray, Ethiopia during the 2021 to 2022 war. So over to you, Balem.
Hello, everyone. As part of the Gender and GBV Accelerator Fellowship Program, this is a privilege to present my findings about help-seeking behavior of sexual and gender-based violence within 72 hours of incidents in Tigray, Ethiopia during the 2021-2022 war. The research question was, how do socio-demographic characteristics influence the uptake of HGBV health services within 72 hours during the Tigray conflict? When we look at why this topic matters is sexual and gender-based violence is weaponized by those seeking military and political power. And between November 2020 and November 2022, the Tigray region, northern Ethiopia, was engaged in civil war and complete siege until the agreement for cessation of hostility in Pretoria. During this time, evidence showed that around 43% of women have experienced at least one type of HGBV. HGBV is known for its association with some physical injuries and chronic pelvic pain and other physical injuries, sexual and reproductive health complications, including unintended pregnancy, unsafe abortion, sexually transmitted infections, as well as mental health issues, which include depression, anxiety, post-traumatic stress disorder, and related social and economic challenges. One-stop centers can provide time-sensitive services for those experiencing HGBV, including emergency contraceptive, post-exposure prophylaxis, critical care services, and referrals. The inability to access services within 72 hours, however, can lead to physical and physiological consequences and fewer legal options. However, in reality, many survivors experience delay in seeking such type of care. Currently, the factors associated with delayed help-seeking integrate context are unknown. Therefore, this study examined the socio-demographic factors associated with accessing HGBV services within 72 hours of incidence during the height of the Tigray War, which is September 2021 to February 2022. Looking at the dataset population measures, the data was collected from registration log from one of the one-stop centers found in the region. The study population were female survivors of HGBV who sought healthcare during the Tigray conflict from September 2021 to February 2022, which accounts for 6 months data. And the exposure variable were socio-demographic characteristics including age, marital status, education, occupation, type of violence, and previous history of HGBV, as well as place of incidence. The outcome of variable was health-seeking behavior within 72 hours of HGBV incidence. Ethical clearance was obtained from Mal University College of Health Science, IRB. Data was analyzed using Stata version 19. This is a map showing the location for one-stop centers in the region. Currently, there are 7 one-stop centers in the region. When we look at the population characteristics of the study population, the age range of survivors varies from 2 to 65 years old, while with a mean age of 27 and standard deviation of 0.47. And about 51% of the sample population were married, and 49% of survivors completed secondary school, and 42% were identified as housewives. Looking at the place of HGBV incidence for 48% of the survivors, the incidence has occurred at home, and around 31% of the survivors reported a repeated history of HGBV. When we look at the main outcome variables of health-seeking behavior, during the Tigray War, the majority of HGBV survivors, accounting for about 95%, didn't seek help within 72 hours of incidence, and further 1 in 10 went to one-stop centers to seek service. This graph indicates about the service availability or uptake in the region. So HGBV survivors seeking help at one-stop centers in Tigray received some services and referrals. Psychological support was the most provided service, accounting for about 96%, while livelihood service were the least provided. Importantly, these referrals doesn't guarantee service utilization. They simply indicate that referral was made, as no follow-up record was available to follow it or confirm actual service receipt. This is indicating the type of violence. Nearly all women, around 99%, who sought help experienced sexual violence, while the remaining 1.9 experienced other forms of sexual and gender-based violence, which may include physical violence or economic violence and the like. Looking at the marital status versus health-seeking behavior, a higher proportion of HGBV survivors who were not married sought help within 72 hours of incidence compared to those who were married. So, however, this association was not significant. And looking at the occupational status, higher proportion of students saw help within 72 hours compared to other groups, like housewives and employed ones. Still, the association was not significant. The survivors of SGBV who experienced incidents in public space, such as at school, office, or within military camps, were more likely to seek services timely as compared to those who were assaulted at home. Survivors assaulted in military camps had 12 times the odds of seeking help within 72 hours, while those assaulted at a school, office, or other public locations had 9 times the odds compared to those who were assaulted at home. And this association was statistically significant. As next steps, looking at these findings, we suggest developing a targeted awareness campaigns about the importance of seeking healthcare after experiencing SGBV, focusing on the urgency of accessing service within 72 hours, ensuring that healthcare services are accessible to all, engaging community health workers initiatives that provide direct support and information about available services, fostering community-based support systems that encourage survivors to seek service, advocating for policies that ensure comprehensive healthcare services for SGBV survivors, including mental health support, legal assistance, and follow-up care, strengthen the implementation and coordination of humanitarian agencies to respond to violence during wartime, and ensure timely and continuous data collection and monitoring of data quality of armed forces during armed forces of sexual violence. These are some of the references. Thank you.
Thank you so much, Balem. That's, again, really, really important work. So if you have any questions, please do put them in the chat or the Q&A box now or at the end of all of our presentations, and we'll have some time at the end. We're now going to move on to our final speaker, who is Dr. Amina Elias Danjuma, who is a Senior Research Monitoring, Evaluation, and Learning Officer at the Foundation for Resilient Empowerment and Development in Nigeria. The title of her presentation is Data Fragmentation in Nigeria's Gender-Based Violence Multisectoral Response System, Challenges in Survivor Tracking and Service Continuity Monitoring. So over to Amina.
Thank you for the introduction. Good morning, good afternoon, and good evening, everyone. My presentation examines data fragmentation within Nigeria's gender-based violence response system. To guide this analysis, the study asked how fragmentation in the coordination of GBV incident and service data influences survivor tracking, service continuity, and outcome monitoring within Nigeria's multi-sectoral response system. GBV data in Nigeria has always been collected by different ministries, agencies, and service providers using separate systems. As a result, information on incidents, referrals, and services are frequently recorded in silos. And this fragmentation makes it difficult to track survivors across sectors, to monitor outcomes, or fully understand the scale of the problem. So to improve coordination, the National GBV Dashboard was introduced as a central platform where sectors can report cases using standardized indicators, as well as the National GBV source documents. This illustration shows how data flows into the National GBV Dashboard. The dashboard integrates information from two key data sources. On the left is the GBV incidents form, which captures details about the incident, including survival characteristics and the circumstances of the violence. While on the right is the service delivery form, which records the support survivors receive across different sectors, such as health, justice, psychosocial support, services, shelter, and even a lot more others. So the both forms are mirrored on the dashboard. And to link records from these two documents, an incident code, which serves as the survivor's unique identifier, while maintaining confidentiality, is required on both forms, so cases can be tracked across services. But when this linkage is missing, it weakens survivor tracking, continuity of care, accountability, and the ability to assess effectiveness of the GBV response system. Also, when this lack of linkage occurs, survivors can become lost across services and may have to repeatedly recount their experiences. Coordination also becomes difficult to monitor, whether referrals lead to actual services, and it also becomes challenging to assess GBV response to inform policy and resource allocation. This framework illustrates the pathway examined in this analysis. Fragmentation in coordination creates weak links between GBV incident and service data sets. And this limits the ability to track referral across the system. So ultimately, these gaps affect survivors by creating challenges in ensuring continuity and completion of services. This study used data from the National GBV Dashboard, which is domiciled at the Federal Ministry of Women Affairs, and we conducted a comparative mapping of variables across the incident and service data sets using traffic light coding to highlight where data capture was complete, partial, or missing. Moving on to the results, this figure compares GBV incident reports and service delivery records by sex and age group across the data sets. In both data sets, females make up the majority of reported cases, and most survivors fall within the 18 to 35 age band, followed by those under the age of 18. And this figure shows the distribution of reported GBV incidents by type. Sexual assault is the most frequently reported form of violence, followed by emotional or psychological violence and physical assault. So this figure compares services needed and versus services provided to the GBV survivors. Psychosocial support and medical services account for the largest share of both needs and services provided, while areas such as legal support, livelihood assistance, and shelter show larger gaps between services that were needed versus services that were actually provided. This table presents the key finding from the analysis. While a few basic demographic variables such as sex and age are captured in both data sets, many other key socio-demographic and service operational variables appear in only one data set, as we can see on the table. And these variables are necessary to monitor services across the GBV response system. But most importantly, the incident code, like I mentioned earlier, which is intended to link the incident and service data sets, is only sparsely captured in the service data. And as a result, records from the two data sets cannot be reliably connected, which significantly limits the ability to track survival pathways, to monitor or track service continuity, as well as to assess the overall effectiveness of the response system. So these findings have important implications for both equity and effectiveness in service provision. When GBV data systems are fragmented, vulnerable groups can become invisible, making it difficult to identify who is underserved or excluded. Also, this creates misalignment between the survivor needs and the support provided, and it makes it difficult to track outcomes. And ultimately, fragmented data systems limit evidence-based decision-making. It reduces the ability to design targeted strategies to improve the overall response system. To address these gaps, Nigeria's GBV response system must standardize and link data across sectors, strengthen referral tracking and shared outcome indicators, and use integrated analytics to monitor survival pathways and guide decision-making. Thank you for listening.
Great. Thank you, Amina. Another really important topic. So we heard from three very related but quite different presentations today, thinking about incidents of femicide in Kenya, to thinking about incidents of sexual gender-based violence during times of crisis and ability to access services within 72 hours in Ethiopia, and now issues with data and monitoring of gender-based violence in Nigeria, which I also imagine is a problem shared by many countries. We're now going to move on to the question and answer period of our session today. So we have about 20 minutes or just under 20 minutes, probably 15 minutes for this. So please do add your questions in the chat box or the Q&A function. And I will hopefully be able to get to all, if not some of them. And while you're thinking of your questions, I will get us started. Josphine, I'll get us started with you, if that's okay. I, found all the presentations really interesting, but your use of the media as a data source, I was wondering if you could speak a little bit more about that. I found that really interesting. Why did you choose media as a data source, and what were some of or how did you use it, and what were some of the challenges that you encountered?
Thank you so much, Rosalie, for that. Yes, I used a collection of the media reports, and this is work that was done by the Africa Data Hub. And why I used that data, because there's no coordinated data for femicide in Kenya. So you cannot go to one particular place and expect to get that data. So it may entail collecting from various agencies. And because that was a bit difficult, so there's this institution that has come up and established a data hub that they collect data on femicide cases across the country. And the data that I used was from 2016 to 2023. So basically, a collection of all this information that has been recorded, but mostly from the media. So it had a lot of challenges, and most of my findings, the unknown bit was taking a huge chunk. The unknown bit because maybe the ages were not reported. The relationship between the victim and the perpetrator was not reported in the media. Remember, this is not primary data that we were using. So, and it was not being collected for this particular work. It was just the data that was, the information that was collected from the media. So I had a lot of unknowns across the various social demographic variables. That is a very big challenge. And that's why one of my action steps is looking at a way of establishing a data hub which can consolidate all this information rather than just going to the media to collect the information, linking the justice sector, the police, and the health sector so that we can get this data in a one-stop shop. Thank you.
Thank you. Yeah, that's really interesting. Just what's what data is not there sometimes is just as important as what's there. And I think the media can be a really interesting source when traditional data sources don't capture what we'd like them to capture. I Not sure. I haven't really been seeing any questions come in, and I'm not sure if it's because no one, oh, we've just have one, I think, which is great. I was like, I'm not sure if it's because no one's putting questions or there's something wrong with the setup, but I could keep coming up with questions. Um, Here. So I see that Io has a question around, is it possible to add implications for research? So the findings are robust to generate implications for research. So I think that many of the presenters did touch upon implications for practice, but thinking about it in the research side, what are some next steps that need to happen? And maybe Balem, I can hand it over to you to get us started.
Thank you, Rosemary. Can you hear me?
Yes.
Oh, thank you. So, probably the implications for future research about my finding would be, this research indicates that probably there might have been worsened physical and psychological consequences of this delayed health care seeking. So probably after strengthening the data sources and analyzing the patterns, getting into the community, there might be a need to analyze the health needs, especially the reproductive health and psychological health needs of the GBV survivors, because we don't know what happened for most of the survivors, which accounts for more than 95%. So there needs analysis of immediate and health needs of the survivors. Thank you.
Great. Thank you. Thank you so much. Amina, over to you with the same question. So what are implications for research?
Thank you. So this analysis basically shows, identifies like major gaps in research, how fragmented data can affect actual tracking and monitoring, as well as the lack thereof of data as well, how it can be a barrier to actually understanding what the scale of GBV problem is in a context. And also it poses a challenge for further research, like a mixed method and more of a qualitative, because the data are is mostly quantitative data. So it's showing like the types of GBV, what is happening, but we're not able to know why these things are happening. So it's posing like questions for further or future research to elaborate or expand research as to knowing why in terms of survivor level as well as systems level, why survivors not completing services, as well as why systems are unable to properly link this data, or what are the cracks really that are happening in the system. So it poses challenges for future research. Thank you.
Great. Thank you, Amina. So Josphine, there's another question for you related to sort of policy. So you could potentially think about this alongside the research questions or the potential research questions. So Josphine, how is femicide prevention being addressed in policy right now? What can your findings tell us about how to prevent femicide?
Okay, thank you, Rosemary, for the two questions. One on the implications for research. Yes, this study has a lot to get from further research, because looking at all the social demographic variables that we were looking at in the study, be it the age of the victim, be it the perpetrator, relationship, we need this more concretized, because like we said, one of the gap was getting this data from the media. So if we can conduct a further research, and especially a qualitative research or a mixed research that combines both the qualitative bit and the quantitative bit, then it will give us more insight into all these issues, be it the age, why girls less than age 18 were killed, and who are these killers? Yes, we are getting to know it is non-intimate partners, but who exactly are these people? And then them home, as we are talking about home being the safest but saddest for women, it is the most place that women are killed. So how do we handle such? Because intimate partner violence is there. It is estimated that 41% of all women, ever married women in Kenya, have gone through intimate partner violence. So what do we do? And this can only come from research. Again, gun-related femicide. All gun-related femicides were by intimate partners. Yet we know guns are not legal in Kenya. They are mainly held by the forces or those who are in the police or the army. So who are these who are killing our women? And some of these answers can only be given, can only be gotten from a further research. So basically, this study has a lot implications for further research. On policy, since femicide has been an outcry for the last 3 years, and the president, recognizing this, put up a technical working group to research, to find out more on GBV and particularly femicide. And the report was handed over to the president last month, and this is the phase that the report is being discussed to see what can be included in the policy, even as we are revising our national policy on gender and development. So these are some of the insights that will be factored into the policy. It is a concern acknowledged by the highest office on the land. So it is going to be given the attention that it deserves. Thank you.
Thank you, Josephine. So if you have a question, just a reminder, please, hopefully if you can use the chat function, do. Also the Q&A function, which is in the control panel at the bottom of the screen. You can click Q&A and then add your question there. Another question for you, Balem, is that they were struck by sort of the difference of seeking care by where the incidents occurred. So individuals in the home, for example, were much less likely to seek care within 72 hours. Just thinking about what does this mean? You know, I think during times of conflict, it's very, very challenging. But what are some sort of practical solutions to try to bridge that gap?
Okay, thank you, Rosemary, for raising a very important question. So, during the crisis time, access to health facilities and for seeking support is very difficult, especially for women. So, to address such challenges, probably integrating GBV services into primary healthcare services and all over widely accessible and nearly accessible health services, including the community health workers, to create community awareness, because we find out that one of the challenges with also community awareness. People don't think that if they went early to health facilities, it would make a change. So community awareness and integration of services would probably elevate the challenges in some cases. Thank you.
Great. Thank you, Balem. Just a quick follow-up question for you as we're focusing on that. What are some of the health impacts of delayed access to care following sexual violence?
Well, more importantly, especially the time-sensitive services for sexual violence would be, as we have seen the findings, for almost 99% of them was sexual violence and rape. So for this, probably the health implication would be like acquiring HIV/AIDS, hepatitis, and unwanted pregnancy. So those are a lifetime and chronic challenges, putting another burden for women's health. So this is a great impact affecting the whole health systems in a country. Yeah, thank you.
Great, thank you. And Amina, for you, the improving data sets is, so important, right? Because again, what we have data on, what we can measure, we can actually do something about. Just wondering if for your awareness, how big is this a problem in other countries? So how transferable are your findings to other contexts?
Thank you, Rosemary. Can you please go over your question again quickly? I had a little background noise.
No problem. So we know that like it's so important to collect data, right? Because what you can collect and what you can measure, you can do something about. And I think your findings really showed, an issue, big issue in collecting data. And just wondering how transferable are your findings to other country contexts? Is this a problem that we see that's widespread?
Okay, looking at the findings is more of a systems level problem, integrating this data across systems, looking at our context in Nigeria, and based on how the dashboard started, it was like a pilot to see how possible it was to actually get like all the sectors, saying that Nigeria is a highly multi-sectoral context for service provision. Survivors have to move through different sectors across different ministries, agencies, and departments to access different services. So it was more of a situation of seeing how we can integrate data into one platform so we have a synergized reporting pattern for GBV data and actually have a harmonized data to tell the entire picture of what the GBV problem is in Nigeria. So in a way to how it can be generalized, well, I feel this model can be replicated in first off other West African countries that we have similar context or mode of service delivery that survivors have to go through different service provision points across different sectors. So I feel this model can be replicated. We haven't gotten it right completely. I mean, that's why we're talking about the fragmentation still, but I think it can be replicated in other similar contexts as Nigeria, where we share the same model of service provision to see how it can be synergized. For the problem, currently we have an ongoing reform that we're currently working with two other countries. I don't know if I'm allowed to speak on that here, but yeah, where we can adopt their own model of integration across the system. So it's more of a system level problem, first of all, the fragmentation. So if we get that right, I think other countries are already consulting and seeing how they can replicate, but we have to get the issue of the fragmented situation of reporting first before it can adequately be replicated across globally, possibly. Thank you.
Thank you, Amina. And our last question today, Josphine, we're going to hand this over to you from Abigail. So from the presentation, it's evident that more research is needed on IPV and concrete steps taken to protect women within the home and marriage. What role does the community play in preventing or responding to IPV as a measure against femicide in Kenya?
Thank you, Rosemary, and thank you, Abigail, for that question, because the community has a great role to play when it comes to prevention of IPV. Mostly, we have seen the community likes to be bystanders, and that is where our biggest problem is, because this GBV happens in a community. Even when it is at home, this home is in a community, and there are neighbors who will come out to say, after a femicide case has happened, that they used to fight. She used to be beaten. They had arguments. They came, consulted us, but until that time reaches when a woman is killed, then we don't get to hear this. So the community has a very big role to play when it comes to prevention of femicide. First, by creating awareness, and then taking charge among themselves so that such cases of femicide cannot occur. And there's also a lot when it comes to research, because we are talking about implications for research. It is the community, again, that can help us in understanding this issue of femicide deeper. So yes, the community has a big role to play. Thank you.
Great. Thank you, Josphine. And again, thank you to all of our presenters for really excellent presentations, very interesting, and for a very interesting Q&A session as well. I'm going to hand it back over to Dr. Decker to close us out.
Wonderful. I have to say, I'm so energized by the learning from each of these sessions and each of these presentations. Josphine from Kenya with the analytics on who is killing our women, and allowing these data to inform our understanding and therefore the solutions for this. Balem, similarly, we're seeing so many actionable things here in these delays in seeking care and also solutions for the sexual violence experiences of survivors. And Amina, I think you put it so beautifully with these integrated analytics, these harmonized data. This allows a true understanding of what's happening in Nigeria, and then paves the way for prevention and supports. So I want to give a huge round of applause to each of our speakers and accelerators for the work, this milestone. And a huge thanks as well to Dr. Ayo and to Nede for joining us, Rosemary for your excellent moderating. And we look forward to our next session as well. We'll be running 2 more evidence webinars. So we look forward to seeing everyone there as well. And in the meantime, congratulations and thank you.